Is it just click down or do I have to use just next week? Yep.
All right, thank you everyone. We'll start again. And our first presenter now is Lesley Hawes, who's going to talk about AMS in general practice.
Okay, thank you everyone. So as Arjun just said, I'm Lesley. I'm tag teaming with Biezen, and I'm going to introduce antimicrobial stewardship in general practice, and then Ruby will discuss an intervention she's currently undertaking in general practice. So I don't need to tell you much about the antibiotic resistance, but the problem is that a lot of GPs don't think it applies to them. They're fine, their prescribing's not a problem, resistance isn't a problem. So there's not a level of huge awareness as such. We do know that most antibiotics are prescribed in general practice in the human medicine, so it is a big area, and we are very high. As you saw with the vets, they were very low antimicrobial prescribers. In humans, GPs are very high on the world stage, so we're above the OECD average. So we do need interventions, but we do have to recognise that in reducing antibiotic prescribing, we do still need to ensure that patients who need antibiotics get them. And it should be guideline concordant, so they get the right antibiotic at the right time, at the right dose, and for the right duration. And that's important because there are a lot of barriers to that as well, which we'll discuss. So basically, any aim that we have to do is basically to improve guideline concordant prescribing of antibiotics in general practice. So if we do that, we'll reduce unnecessary prescribing and we'll make sure patients get the right antibiotics, etc., at the right time. So we have a lot of issues. One of them is prescribing guidelines. We do have prescribing guidelines. They're the same ones that are used in hospitals, but GPs don't get the same level of access to them. And even if they do have them, they don't integrate with their software. So they're cumbersome to use, and so they tend not to be used, and GPs tend to prescribe from habits, just as we were hearing with the vets as well. And then data monitoring. We don't know why the prescription was written. It's not written on the prescription, so we don't know. We can't check it with guidelines. All we can do is look at they prescribed a lot. So we don't know what it was prescribed for. And then we have demand, a bit like in veterinary as well. Patients expect their antibiotics. They feel miserable, they're sick, and our culture is you go and you get something to get fixed up and you feel better. So there is a patient demand. Some of it is perhaps more perceived than real, but there is still a demand, and it varies. Again, it would need to be a cultural implementation because there are different demands from different cultures, and it also has a bearing on health literacy of those people as well. The other problem with any intervention in general practice is GPs are busy. They're only funded partly for time face-to-face with the patient. So if they were to undertake an antimicrobial stewardship activity, it's basically unfunded. And in the latest health assessments, we know that 49% of GPs perceive that they have an excessive workload already, and a quarter of those think that it sometimes interferes with patient care. So we can't put anything too onerous on GPs. We have to bear that in mind. So any intervention has to fit within GP workflow. So we've got a lot of issues there. I've only touched on some of them. There are many more. So when we look at our target groups and levels of interventions, our GPs need those clinical decision support tools, which are things like antimicrobial guidelines integrated into their software. They need patient information tools to help explain to a patient, no, you really don't need antibiotics for your bronchitis. I know you've had them every time you get bronchitis, you've had them, but you don't need them this time. How can they convince the patient? Shared decision-making skills, talking with the patient, getting the patient to work out what their priorities are and accommodating those. along with what the GP thinks is necessary. So there's a lot of training needed in attaining those skills. And then there's, of course, the audit and feedback I touched on before. So GPs need to be able to access their data and audit it. Now, it's very difficult for some GPs. The clinical software isn't always intuitive. Some GPs have not got a clue how to do an audit. GP software, GPs are private businesses like vets, but they can order any software they want. So lack of interoperability has been an issue for, say, if we had the primary health networks downloading it. We're now overcoming those problems, so we can now access the data. But unfortunately, we can't access things like patient notes because of privacy issues. We can only access certain fields. And the field for the reason for prescription is not useful to the GP. So one of my studies showed that only 17% of antibiotic prescriptions had anything useful written in there that we could use. So that's the GPs. Then we come to patients. Well, of course, they need education on antibiotic resistance and also the side effects of antibiotics use. There's a perception antibiotics are miracle drugs. They're fine. But of course, as we all know, they can have side effects. And they need to understand the risk versus benefits of antibiotics for their condition. Because you hear sometimes of patients, I don't want antibiotics, but they actually need them. Then there's the government and the organisation levels. We need to support GPs with all these appropriate tools. Who develops them? Who puts them on their website for GPs to access? And then, of course, incentives. As I said, GPs are basically only paid for time face-to-face with the patient. If we're going to improve guideline compliance, do we need to incentivise it? And so on. So we've got a whole list of key stakeholders and their roles. So the GPs, they diagnose patients, they prescribe the antibiotics, and they receive back the results of the audit with feedback that's hopefully actionable. Practice staff haven't been looked at. They can facilitate any implementation. They talk with patients. They understand what GPs and patients' needs are. The patients themselves are the recipients of care. They come seeking the GP review and option. And then, of course, there's the researchers. We're the ones driving these because the GPs are not actually necessarily asking for this. And we're analysing. We provide that feedback to the GPs. There are pharmacists, unlike vets who prescribe and dispense. GPs prescribe, but the pharmacies dispense. Pharmacies also do patient triage to a certain extent. A patient goes to the pharmacist and says, I've got this, this, and this. And the pharmacist might say, you need to go to the doctor for antibiotics. Or they might say, here's some over-the-counter things. Well, what messages are they giving as well? And they can also have a role for over-the-counter or non-antibiotic medications. I've mentioned the difficulties with the medical records, so we need to work with them to integrate those reasons for prescription and make it useful for the GP. Then they will fill it in. Make the guidelines cooperate with the medical record. And the government bodies to fund the therapeutic guidelines and produce the incentives. So that's a sort of broad overview. Then I'm going to leave Ruby now to talk about this particular intervention to follow on.
So thanks, Lesley. It's not all doom and gloom. I'm actually the lucky person at the other end of this that we're able to start building some of these interventions by working out what the problems are and be able to develop and pilot and test these interventions. So I was just saying to Lesley when I was doing the presentation, I was actually a little bit boring as compared to the other previous presentations. We pretty much just stuck with the questions that Brian's given us. So you can see that hopefully it follows on what we've been talking about. So Brian gave us the template. What are the main study questions? So at the Department of General Practice at the University of Melbourne, we collaborated with the National Centre of Antimicrobial Stewardship, and we've developed a program of work to address these main questions. So the main question is, how do we guide optimal antibiotic prescribing in general practice with a view to promoting prescribing that is concordance with recommendation in evidence-based guidelines and reduce unnecessary antibiotic prescribing? So if you can say the first four are actually the different studies across the main program of work. And the question we wanted to ask in the first instance is, how do GPs use their electronic medical record and guidelines to make antibiotic prescribing decisions? Then we did what we call GP NABs, which I'll explain a bit later. What feedback do GPs require to improve key antibiotic prescribing indicators, such as documentation of indication and appropriateness of antibiotic prescribing? Then we moved into a co-design phase, and the questions that we actually wanted to ask is, what is the acceptability and feasibility of a clinical decision tool that we have developed to integrate within the electronic medical record? Same sort of question, because then we did a simulation study, and then we actually then built this program of work called a guidance GP. So what are the barriers and facilitators? And does the program result in an increase in the proportion of compliance and appropriateness of prescribing? So if we want to break this up into the main study design, so this study, the qualitative study, was aimed to explore how general practitioners access and use both guidelines and electronic medical record to assist clinical decision making when prescribing antibiotic in Australia. The study design was the qualitative study. We conducted 5 focus groups with 26 GPs across Australia to answer the question, which is what we proposed before: how do GP use the EMR and guidelines to make antibiotic prescribing decisions? If you want the result, the paper's out. I can give you the paper later on. So GP NABs was actually conducted across 11 practices, but the problem with the GP NABs was we tried to replicate what was in the hospital NABs or the surgical NABs or in vets, but we couldn't do that because GP had a different type of collection with the data. So we had to manually go into 11 practices to extract these data. So it was never going to be a feasible thing. So what we did was we did the auditing of antibiotic prescribing. We collected 50 consultations per practice and collected data including the patient demographics, the type of antibiotics, the routes, the dosage, frequency and duration, to assess the compliance to therapeutic guidelines, which is our national guidelines, and also appropriateness of the antibiotics for that condition. So the data were then analysed and provided in the report for each practice. So that is your audit and your feedback loop. And then an education webinars were also conducted to discuss the project in itself, provide key feedback to these GPs. So that actually answers the question, what feedback do GPs require to improve key antibiotic prescribing indicators, such as documentation of indication appropriateness? So arming with the information from the qualitative study and some of the feedback that we got from GP NABs, we next designed a clinical decision support tool. We actually used it as a co-design phase. So we asked GPs to come and help us develop this clinical decision tool to integrate therapeutic guidelines within the electronic medical record. In that session, we discussed what was acceptable in terms of the layout, the format and the tools to answer the question, what is the acceptability and feasibility of this clinical decision tool? So once the tool was developed, we needed to test it to see whether it's actually acceptable and feasible. So with the prototype, we conducted simulation studies with 8 GPs using 2 clinical cases with 2 live patient scenarios. So the GPs were consulting with these patients as if they were in their own practice. GPs were then asked to complete a demographic survey, then rate how realistic the consultation was, and then we asked them to complete a post-study usability questionnaire and the system usability scale. This was also followed by think aloud interviews. So what we asked them to do was talk us through exactly what they were doing while they were consulting. So the CDS tool was then refined further, and we're now in the next phase, which is what we call the guidance GP. So these are the key features of this intervention program that we've developed as Guidance GP. So we're about to start to pilot across 4 practices. So we're putting a baseline GP NAPS audit, and then in that 2 weeks audit, we actually have the tool to pop up if the GP doesn't have an indication when they prescribe any antibiotics. And then there's a pop-up tool. Now, the pop-up tool doesn't actually come up if the GP have put in an indication for the reason for prescription. Only pops up when it doesn't. So after the 2 weeks, we'll gather that information. We'll give them a feedback report, and we'll run a webinar just to let them know how they're going. And we benchmark practice to practice, although there has been requests to benchmark GP to practice and GP across all practices, but at this stage we're only doing practice to practice. Then we're going to install this clinical decision support tool for 6 months to see whether it actually helps GPs assist them in their prescribing during that time. We also have we've also collaborating, is that the word, Rachel? Collaborating with the Northwest Melbourne PHN. So what they're actually doing is they're forming the quality improvement program and support for these practices as well. So after the intervention period of 6 months, we will follow up doing a separate GP NAPS audit, and we'll do the same thing, give them feedback report and webinar. And then we will complete the quality improvement activity with these practices. So we had to have a deep think about this theoretical framework, because obviously it's very important. So basically, by analysing the qualitative data initially from the focus group, the think aloud interview and the quantitative data from GP NAPS, we're able to answer some of these questions. So that actually comes in the knowledge inquiry, knowledge synthesis, and knowledge tools and product. So what we've done is we've done the knowledge cycle, or the knowledge part, and then we've built, using that knowledge, we built the tool, the clinical decision tool. So I probably should have said that the knowledge to action framework. So the framework consists of the knowledge creation, which is the middle part, and the action cycle, which is where we're going in. So the action cycle is basically what we're going to be using to evaluate the GP NAPS product tool. A lot of you are familiar with this. I did my whole PhD on theoretical domains framework, and I think I pretty much loathe looking at one of those little circles again, but it's a very, very useful tool. So the theoretical domains framework will be used to analyse the data for the change in behaviour, not only just in general practice, but I mean GPs, but also in patient as well. So we're going to be evaluating that. The next framework, which is I think they keep calling it CFIR, the Consolidated Framework for Implementation Research. So I'm not as familiar with that, but apparently while the theoretical domains framework, or the TDF, it's going to look at behavioural change using capability, opportunity and motivation at the individual level. So we're talking about GPs and patients and practice staff. The practice level, which is, we'll be looking at the practice culture and the environment, and also the organisation level. So the medical record vendors, as Lesley was talking before, and the government bodies. The CFIR framework will help us understand which factors may affect the intervention implementation. I think I ran out of puff when I got back to this question, evaluation framework and key measures. So I thought about how we actually evaluate the framework and what key measures that we actually need. So we can measure it by the reduction of inappropriate antibiotic prescribing as determined using pre and post GP NAPS data. So we can actually measure then we can actually determine the acceptability and feasibility of the GP NAPs using the audit feedback data and improve appropriate antibiotic prescribing. And also certainly with the PHN's help in the quality improvement program, we can actually do that. We can also assess the acceptability and feasibility of the CDS tool with this TG button on the side to actually help. Steve actually helped GPs with their workflow. And so we can collect some of the GP focus group data. And we can't ever forget the patient, because the patient is the centre of all our work, because better patient outcome will actually give us more incentive to make sure that the GPs are doing what they should be doing and want to be doing to help eventually the outcome of patient satisfaction and really health outcomes. So I think that is it. Thank you. Stunned audience, I like it.
Well, thank you, Lesley and Ruby.
Okay.
I might take a few questions. Do you have any questions?